Мы разговариваем со знаменитым профессором из Германии, это Dirk Schadendorf. Dear professor, glad to meet you in Russia. Please tell us how is the situation in Germany with melanoma patients with first and second and third stage and BRAF mutation?
Oh, I think it's very important for the patient, but also for the doctor to know the BRAF status. So everybody has to take care that BRAF status is being determined, that the tissue is being examined. So pathologists should do the job, and if that's not done, dermatologists, surgeon, or who else sees the patient should make sure that there is a BRAF testing results in the charts.
Do you mean that each patient has to do BRAF mutation test?
Definitely in the metastatic stage 4, definitely now with the treatment options in stage 3.
And what about the stage 2?
Yes, I think if there is a high-risk primary tumor, I think it would be good to have a BRAF testing result already available, that in case of a progression either into stage 3 or into stage 4, you are ready to go and don't have to wait for weeks for a BRAF testing or to dig out the tissue.
What do you think if the patient with a stage 2 has a BRAF mutation and it is positive, what he has to do?
I think he should keep the BRAF testing result in a spot where he can find it easily, in order to show it to the doctor if needed. Right now we have only clinical studies emerging in stage 2 melanoma with primary.
What does it mean?
So that means that we have only clinical trials which are looking for adjuvant treatment in stage 2 right now. Studies are starting, so we will have to wait 5 years or longer before we have results with that.
But what do you think? If the patient has stage 2, does he have to demand the sentinel biopsy?
That's a difficult question. So in Germany, in the guidelines, it's a clear statement that in stage 3 and in stage 4 that should be done. I think a good, excellent center is offering that already with high-risk stage 2 to the patient. Because, as I said, treatment planning in later months or years is becoming much easier if that result is available, because usually these patients have a relapse only after 3 years or 4 years. Then you have to look, where is the tissue? Is still tissue there? And if you have already a result, the treatment decision whether you are eligible for a BRAF-MEK combination can be taken much quicker than if you have to search for tissue, because not in all cases it's easy to biopsy a tumor. If you think if there are lung metastases only, it's difficult to get tissue again in a lung metastasis.
Thank you very much. But when a patient got this diagnosis on early stage in situ, what he has to think of?
In cytomelanoma, it's clear that this is not an invasive melanoma. So what we know is cut it out. Make sure that the pathologist has seen that there is an in situ melanoma only, and then you are safe. There is no reason to be afraid. This in situ melanoma will be cured just by surgery.
But does the patient forget about it, or just watch it or pay attention to it for the rest of his life?
No, I think this lesion which was cut out, you can forget. But if you have a skin tumor, like in situ melanoma, the risk that you are developing a second or possibly even a third skin cancer is high, because obviously you are at risk of developing skin cancers. And if you are developing a squamous cell carcinoma or any other kind of epithelial skin cancer, this will not lead to death or that you are threatened to die, but other types of melanomas might be also increased. So we know that patients who have one skin cancer have a risk to develop a second skin cancer and melanoma in the range of 10%. And the main reason not to forget about it is that in order to avoid a second skin cancer and treat this second and or third skin cancer early enough.
So pay attention and watch the rules.
Absolutely.
Thank you very much.
Yes, thank you.